Story 1. The float nurse's misfiled patient. I found him again in room 407, though the bed count didn't allow for it. The census showed 12 patients on the floor. I'd counted 13 beds occupied. His chart flickered on my tablet, there for 30 seconds, gone the next time I refreshed. When I asked the charge nurse about the discrepancy, she looked at me with genuine confusion and said, "We don't have a 407 on this unit." I was standing directly outside it. I'd been a float nurse for 8 years before that October, rotating between units as staffing demanded, filling gaps wherever the hospital census created them. It was demanding work, requiring constant adaptation to different workflows, equipment locations, and staff personalities, but I'd developed a rhythm. I prided myself on my ability to orient quickly, to absorb a unit's culture within the first hour of a shift. That confidence made what happened on the medical surgical floor that night particularly disorienting. The assignment came through at 6:45 p.m., 15 minutes before shift change. Med-Surg was short 2 nurses due to call-outs, and they needed coverage for a 12-patient assignment split between the 4th and 5th floors. I arrived during report, listening as the day shift nurse rattled through patient conditions, pending discharges, and medication schedules. Everything seemed routine. The unit was older, with that particular institutional smell of disinfectant and reheated cafeteria food, but well maintained. The nurses seemed competent if exhausted. I took my assignment sheet and began my initial rounds at 7:30 p.m., moving methodically from room to room, introducing myself, performing assessments, verifying IV lines and medication orders. The 4th floor had 6 patients under my care. I checked each one, documented vitals, responded to call lights. By 9 p.m., I'd established my routine and settled into the particular rhythm of that unit. The elevator that groaned on ascent, the ice machine that rattled every 20 minutes, the way the fluorescent light in the med room flickered when the HVAC kicked on. It was during my 10 p.m. med pass that I first noticed the discrepancy. My tablet showed 7 patients assigned to me on the 4th floor, not 6. The 7th name, room 407, patient surname Aldrich, appeared at the bottom of my list. I didn't remember receiving report on an Aldrich. I scrolled through my notes from shift change and found nothing. When I checked the written assignment sheet I'd been handed, it listed only 6 names for the 4th floor. I walked to room 407, located at the end of the hallway, past the nurse's station, in a section of the corridor that seemed slightly dimmer than the rest. The door was closed. I knocked softly and entered. The room was cold, noticeably colder than the hallway, and smelled faintly of something I couldn't identify. Not unpleasant, but distinctive. Metallic, almost. The patient, a man who appeared to be in his late 60s, lay in the bed nearest the window, awake and watching me with calm, dark eyes. An IV line ran to his left arm. The monitor above his bed displayed steady vitals. Heart rate 72, blood pressure 118/76, oxygen saturation 97% on room air. "Good evening, Mr. Aldrich," I said, checking the tablet. His chart had minimal information. "Admitted for observation following an unspecified incident. No listed diagnosis, no medication orders beyond basic saline lock maintenance. I'm Carolyn, your nurse tonight. How are you feeling?" He smiled slightly. "I'm well, thank you. You're new to this floor." "Just for tonight," I said, scanning the room. Everything appeared normal. Call button within reach, bed rails appropriately positioned, no fall risk indicators. "Do you need anything? Pain medication, water?" "No, thank you. I'm quite comfortable." I documented the interaction and moved on to complete my remaining rounds. When I returned to the nurse's station at 10:45 p.m. to chart, I pulled up Aldrich's file again to document my assessment. The chart was gone. My patient list showed only 6 names for the 4th floor. I refreshed the screen, still 6 patients. I searched for Aldrich in the hospital's patient database. No results. I checked the census board mounted on the wall behind the desk, the physical board that listed room numbers and patient initials. Room 407 was marked as empty. I walked back to room 407. The patient was still there in the same position, watching the darkened window. The monitor still displayed his vitals. I could hear the steady beep of his heart rate. I could see the rise and fall of his chest. "Mr. Aldrich," I said quietly, "can you tell me when you were admitted?" He turned his head toward me slowly. "I'm not certain of the exact date. Some time ago, I think. The days tend to blend together here. Do you remember why you were admitted?" "An incident," he said, echoing the vague language from his chart. "Something that required observation." I returned to the nurse's station and approached the charge nurse, a woman named Rebecca who'd been on the unit for 15 years. "Can you tell me about the patient in 407? Rebecca looked up from her computer. "What do you mean?" "Room 407, the patient down at the end of the hall." She frowned. "Carolyn, we don't have a room 407 on this floor. This unit only goes up to 406, always has." I felt something cold settle in my chest. "I've been in that room twice tonight. There's a patient there, Aldrich, elderly male, stable vitals, admitted for observation." Rebecca's expression shifted from confusion to concern. "Are you feeling all right? Do you need to take a break?" I walked back to room 407 with Rebecca following. I opened the door. The room was exactly as I'd left it. The patient lay in the bed. The monitor beeped steadily. The IV line hung from its pole, saline dripping at a measured rate. Rebecca stood in the doorway, looking into the room. "Carolyn, that's a storage room. We keep extra linens and equipment in there. There's no bed, no patient." I turned to look at what she was seeing. For just a moment, less than a second, I saw it too. Metal shelving units, stacked blankets, a wheelchair folded against the wall. Then the image stabilized back into the patient room with Aldrich watching both of us with that same calm, knowing expression. "You see him, don't you?" I asked. Rebecca shook her head slowly. "I see storage. I'm going to call the supervisor. I think you might need to go home early." I didn't argue. I completed my shift in a fog of confusion, avoiding the end of the hallway, focusing on my other 6 patients. But every hour when I checked my tablet, Aldrich's name would appear for 30 or 40 seconds before vanishing again. At 2 a.m., I found myself standing outside room 407 without consciously deciding to walk there. The door was open. The patient was gone. The bed was stripped, but the monitor was still on, still beeping, still showing vitals for someone who wasn't there. I documented everything in my personal notes, though I knew I wouldn't submit them officially. At 6 a.m., I gave report to the day shift nurse. I mentioned 6 patients on the 4th floor. She confirmed 6 patients. I asked her carefully if she'd ever heard of a room 407. "That's the old isolation room," she said absently, reviewing her assignment sheet. "Hasn't been used as a patient room in decades. They converted it to storage back in the 90s after some kind of incident." "Why?" I didn't answer. As I gathered my belongings from my locker and prepared to leave, my tablet chimed with a notification. A new message in the hospital's internal communication system. I opened it. The message was blank except for a room number, 407. The sender field showed my own name. I haven't been assigned to that unit since that night, though I've requested it multiple times. Each time, staffing coordinators tell me the 4th floor medical surgical unit doesn't need float coverage, hasn't needed it in months, despite the hospital's ongoing staffing shortages. When I look up the unit in the hospital directory, it lists rooms 401 through 406. But sometimes, late in my shifts on other floors, I'll see a message flash across my tablet. Just for a moment. too quick to capture with a screenshot. A patient name, Aldrich. Room 407, always requiring assessment, always waiting. I've stopped trying to explain it. Some patients exist in the margins of documentation, in the spaces between what the census shows and what the hallways contain. They're always there, always assigned, always needing care that can never be properly charted because the system refuses to acknowledge they exist at all. And sometimes I wonder if I'm the one being misfiled. Story 2. The respiratory therapist's second call. The page came through at 2:47 a.m. Rapid response, room 512, respiratory distress. I was already running when I realized I'd responded to this exact call 9 minutes earlier. I'd intubated the patient, stabilized her oxygen saturation, documented the intervention. But when I burst into room 512, the patient was sitting upright, gasping, unintubated, staring at me with terrified recognition, whispering, "You were just here. You said you'd stay. Where did you go?" I'd worked as a respiratory therapist for 11 years when the doubling started, most of that time on night shift at County General, a mid-sized teaching hospital with a level 2 trauma center. The work suited my temperament. Methodical, technical, focused on immediate physiological problems with clear interventions. Patients couldn't breathe. I helped them breathe. The simplicity of that exchange appealed to me even during the most chaotic codes. Night shift respiratory typically ran with 2 therapists covering the entire hospital. My partner that rotation was a newer graduate named Eric, competent but still building his confidence with critical interventions. We'd divide the hospital geographically. I'd take the north tower, he'd take south. We'd respond to pages independently unless the situation required both of us, which happened maybe once or twice a week. The first doubled call occurred on a Tuesday in late September. At 11:23 p.m., I received a page for a nebulizer treatment in room 734. A chronic COPD patient named William Garrett who typically required breathing treatments every 4 hours. I walked to the 7th floor, gathered my equipment, and knocked on his door before entering. The room was dark except for the glow of the television. Garrett was awake, sitting upright in bed, his breathing audible and labored. "Evening, Mr. Garrett," I said, setting up the nebulizer. "Let's get you breathing easier." He looked at me with an expression I couldn't quite read, not confusion exactly, something closer to déjà vu. "Didn't you just leave?" "No, sir. I haven't been up to your room since about 7:30. "Oh," he frowned. "Must be mixing up my nurses." I administered the treatment, staying with him for the full 15 minutes while he inhaled the medication. His breathing eased. His oxygen saturation improved from 89% to 94%. I documented the intervention on my tablet and returned to the respiratory office on the 1st floor. At 11:51 p.m., 28 minutes after the first page, I received another call for room 734. Nebulizer treatment for William Garrett. I checked my tablet. My documentation from the previous treatment was there, time-stamped 11:40 p.m. I'd already treated him. I called up to the nursing station on the 7th floor. "This is RT. I'm showing a duplicate page for Garrett in 734. I just completed a treatment there about 20 minutes ago." The nurse sounded puzzled. "That's strange. His chart shows his last treatment was at 7:30. He's due now." I walked back to the 7th floor, more curious than concerned. Duplicate pages happened occasionally due to system glitches or miscommunication. When I entered room 734, Garrett was sitting in exactly the same position as before, breathing with the same labored pattern, wearing the same expression of confused recognition. "You're back," he said. And this time it wasn't a question. I checked his oxygen saturation, 89%. Exactly what it had been at the start of my previous visit. "Mr. Garrett, do you remember me being here a few minutes ago? You gave me the breathing treatment. Sat right there in that chair. We talked about the weather. Then you left and now you're back. What did I say about the weather? You said it was supposed to rain tomorrow. Strange thing to bring up, since I mentioned it first. I hadn't said anything about the weather during my previous visit. We'd barely spoken. I administered the treatment again, watching him carefully. His breathing eased. His saturation improved to 94%. Identical results. This time I documented the intervention but flagged it in my personal notes. Possible duplicate call, patient reports previous visit with same treatment. Over the following week, the doubled calls became more frequent. I'd respond to a rapid response for respiratory distress, intubate a patient, stabilize their condition, document everything properly. Then, 15 or 20 minutes later, I'd receive another page for the same patient, same room, same crisis. When I arrived, the patient would be in distress again, not intubated, showing no evidence of my previous intervention. But their eyes would track me with recognition, and they'd say things like, "You were just here," or "Did you forget something?" The most disturbing aspect wasn't the repetition itself, it was the details the patients remembered. A woman in the ICU, post-surgical respiratory failure, whom I'd intubated at 1:15 a.m. When I responded to the second page at 1:38 a.m. and found her unintubated and struggling to breathe, she grabbed my wrist and said, "You told me I'd be asleep before I felt anything. You promised it wouldn't hurt." Those had been my exact words during the first intubation, spoken to calm her panic. A teenager with status asthmaticus in the ER, whom I'd treated with continuous nebulizers at 3:42 a.m. When the duplicate page came through at 4:10 a.m., he was sitting on the edge of the bed in active distress, and when I entered, he said, "You already checked my peak flow. It was a 180. You said that was better than when I came in." True, documented. But according to the chart, I hadn't treated him yet. I started keeping detailed notes of every intervention, exact times, specific conversations, patient responses, equipment serial numbers when available. I compared my documentation to the hospital's official records. They never matched. According to the system, my first interventions never happened. Only the second ones existed in the database. But the patients remembered both. I began arriving at calls faster, trying to catch whatever was creating the doubled responses. If something or someone was mimicking my interventions, I wanted to see it directly. At 2:34 a.m. on a Saturday, I received a page for respiratory distress in room 428. I ran the 4 flights of stairs instead of waiting for the elevator. I arrived outside the room 90 seconds after receiving the page. The door was closed. Through the small window, I could see a figure standing beside the bed, dressed in respiratory therapy scrubs identical to mine, holding a bag valve mask, ventilating the patient with practiced, efficient movements. The figure's back was to me. Same height as me. Same build. Same dark hair pulled into the same ponytail. I opened the door. The room was empty except for the patient, who was lying in bed, struggling to breathe, unventilated. No other RT, no equipment except what was mounted on the wall. The patient's eyes fixed on me with desperate recognition. "Help me," she gasped. "Please. You left. You said you'd stay until I stabilized, but you left." I'd received the page 90 seconds ago. I hadn't been in this room before, but I could see the indentation in the chair beside the bed where someone had been sitting. I could see the bag valve mask lying on the bedside table, still warm when I picked it up, as though it had just been used. I treated the patient. I documented everything. I didn't mention what I'd seen through the window because I wasn't certain what I'd seen. The doubled calls intensified. Sometimes the gap between the first and second page was only 5 or 6 minutes. I started encountering patients who were confused about which version of me they were speaking to. "Are you staying this time?" they'd ask. Or did you bring the different oxygen mask you mentioned? I never mentioned different equipment. The other version of me did. Eric, my partner, noticed my growing anxiety. You seem off lately, he said during a rare quiet moment in the respiratory office. Everything okay? Do you ever get duplicate pages? I asked. Same patient, same complaint, like you're being called back for something you already handled? He shook his head. Not really. Sometimes nurses page again if they think the treatment didn't work, but that's different. Why? I couldn't explain it in a way that sounded rational. The night it escalated beyond doubling, I was responding to a code on the cardiac floor. Full arrest, patient requiring immediate intubation. I arrived at a sprint, equipment ready. The code team was already in the room. I pushed through to the bedside and prepared to intubate. The physician leading the code looked at me with irritation. We already have RT here. Where's your partner? I turned. Standing on the opposite side of the bed, holding an intubation kit, was another version of me. Same face, same uniform, same ID badge. She looked at me with an expression of calm assessment, as though measuring me against some standard I couldn't perceive. I've got this, she said, her voice identical to mine. You can go. The code team didn't react as though anything unusual was happening. They worked around both of us as though having two identical respiratory therapists at a code was perfectly normal. The other me intubated the patient with flawless technique. The same technique I would have used, the same hand positioning, the same gentle advance of the tube. I backed out of the room slowly. No one stopped me. No one seemed to notice I was leaving. I found Eric in the main corridor. Did you just see that? I demanded. See what? In the code. There were two of me. He stared at me. Morgan, are you sure you're okay? Do you need to go home? I completed the rest of my shift in a state of careful documentation. Every call I responded to, I noted whether I saw evidence of previous intervention. Most showed signs, equipment positioned as I would position it, settings adjusted to my preferences, patients who recognized me and remembered conversations I hadn't had yet. The other me was becoming more efficient, more present, responding faster, treating more patients, building a parallel record of interventions that seemed to be slowly overriding my own. I requested a meeting with my supervisor. I tried to explain the situation calmly, clinically, presenting it as a documentation issue or perhaps a system glitch creating phantom records. She listened with growing concern and placed me on administrative leave pending a fitness for duty evaluation. I haven't been cleared to return to work yet. The evaluation is ongoing, but I still receive the pages on my old hospital pager, which I forgot to return. Calls for respiratory emergencies, ICU ventilator alarms, rapid responses for patients in distress. They come through at all hours. I don't respond to them anymore, but I imagine someone does. Someone wearing my face, using my credentials, building a more complete record of interventions than I ever managed. Sometimes I wonder if the doubling started as a glitch or if it was always the plan. A slow replacement, so gradual that no one would notice when the original version stopped showing up entirely. The patients remember both versions because both are real. Both respond, both treat. But only one is becoming permanent. I still get the pages. Each one a reminder that somewhere in that hospital, during every crisis, someone who looks exactly like me is arriving first, staying longer and doing the job I used to think was mine. Story 3. The Psychiatric Intake Nurse's Quiet Room. The intercom crackled at 4:17 a.m. with a voice I recognized as my own, calm and professional, saying, "Patient in quiet room 3 is ready for re-evaluation." I was standing at the nurse's station when I heard it. I'd never activated that intercom. According to the unit logs, Quiet Room 3 hadn't been occupied in 8 years. But when I pulled up the chart, I found 53 pages of intake notes in my handwriting, documenting hourly assessments of a patient I'd never met, dating back to 3 months before I was hired. I'd worked in psychiatric intake for 6 years at the time, all of it at Riverside Behavioral Health, a secure facility specializing in acute psychiatric crisis intervention. The intake unit occupied the second floor of the oldest wing, a section of the hospital built in the 1960s and only partially renovated over the decades. The unit housed 12 beds and 3 quiet rooms, windowless observation rooms used for patients requiring intensive monitoring due to safety concerns. My role was to conduct initial psychiatric assessments for all admissions, typically between 5 and 8 patients per night shift. The work required a particular kind of sustained attention, listening to someone describe their crisis or psychosis while simultaneously evaluating their mental status, risk level, and appropriate treatment pathway. I was good at it. I developed an instinct for the rhythms of psychiatric distress, for distinguishing between genuine crisis and manipulation, for calibrating my responses to de-escalate rather than inflame. The locked unit had its own particular atmosphere, quiet in a way that felt deliberate rather than peaceful, with the constant low-level awareness that every door required a key card, every patient interaction carried potential volatility, and every moment of calm was temporary. I'd grown comfortable with that tension. It felt manageable, predictable. The first time I noticed the quiet room discrepancy was during a routine check of the unit census in late October. I was reviewing the patient board at the nurses' station at approximately 11 p.m., confirming room assignments and acuity levels for my shift. The board showed 11 patients, 9 in regular rooms, 2 in quiet rooms 1 and 2. Quiet room 3 was listed as vacant, which was standard. I couldn't remember the last time we'd used all 3 quiet rooms simultaneously. But when I pulled up the electronic chart system to begin my assessment documentation, I saw 12 active patient charts. The 12th was assigned to quiet room 3. Patient surname, Novak. Admitted for acute psychotic episode with disorganized thinking and auditory hallucinations. Attending physician, Dr. Khalil, who I knew well. I walked to the charge nurse, Helen, who was reviewing medication orders at her computer. "Do we have someone in quiet room 3? She looked up, frowning slightly. "No. Why?" "The system is showing a patient assigned there, Novak." Helen pulled up her own view of the census. "I'm showing quiet room 3 as empty, has been for months." She paused, studying her screen. "Actually, according to this, quiet room 3 has been out of service since 2016. Some issue with the observation window. Maintenance never repaired it, so we stopped using it." I showed her my tablet. The patient chart was clearly visible, complete with admission time, preliminary diagnosis, and a treatment team assignment. Helen's expression shifted to something I recognized from years of psychiatric work, the carefully neutral look that meant she was assessing whether I was experiencing something that required intervention. "Jenna, I don't see that on my screen. Are you feeling all right?" "I'm fine. Look." I turned the tablet toward her, pointing at the chart. She looked at the screen, then back at me. "That's showing the census list, 11 patients, no Novak." I looked at my tablet. The 12th chart was gone. 11 patients, no quiet room 3 assignment. I refreshed the screen several times. 11 patients. I logged out and back in. 11 patients. I felt a prickle of unease that I forced down through practiced clinical detachment. "Must be a system glitch," I said evenly. "Sorry to bother you." "No problem. Let me know if you see it again and we can call IT." I continued my shift, focusing on the 11 documented patients. I completed intake assessments on 2 new admissions, administered medications, responded to a behavioral incident in room 8 that required de-escalation and PRN sedation. Standard night shift workflow. At 2:30 a.m. during a quiet period, I walked past quiet room 3. The door was at the far end of the hallway, past the regular patient rooms in a section of the unit that received less foot traffic. The door was closed, as always. The small observation window, which should have allowed staff to view into the room, was covered from the inside with what looked like paper or fabric. I'd walked past this door hundreds of times and never noticed the covered window before. I used my key card to unlock the door. The quiet room was small, approximately 10 by 12 feet, with padded walls and a ceiling-mounted camera for continuous observation. The camera's indicator light was off, suggesting it wasn't recording. The room was empty except for a standard hospital mattress on the floor and a single blanket. But the room smelled lived in. Not unpleasant, but distinctly occupied. And on the wall opposite the door, someone had written in pencil, very small, almost invisible unless you were looking for it, "Ask about the interviews." I backed out of the room and returned to the nurses' station. I pulled up the observation camera feeds for all 3 quiet rooms on the central monitor. Quiet rooms 1 and 2 showed clear video of the patients inside, both sleeping. Quiet room 3's feed showed static. I checked the maintenance logs. The last entry for quiet room 3 was dated April 2016. Observation window damaged, camera malfunction. Room removed from active use pending repair. I checked the patient admission database, searching for any patient with the surname Novak admitted to the psychiatric unit in the past year. No results. I expanded the search to 5 years. No results. 10 years. Nothing. At 4:17 a.m., the intercom system crackled to life. The voice that came through was calm, professional, and unmistakably mine. Patient in quiet room 3 is ready for re-evaluation. I was standing at the nurse's station when I heard it. My hand was nowhere near the intercom controls. Helen, who was charting at the desk beside me, didn't react at all, as though she hadn't heard it. "Did you hear that?" I asked. "Hear what?" The intercom crackled again. My voice. "Patient reports decreased auditory hallucinations. Affect remains flat. Requesting medication evaluation." Helen continued charting, completely unresponsive to the broadcast. I walked quickly to quiet room 3. The door was closed. The window was still covered. I unlocked the door and pushed it open. The room was empty. Same mattress, same blanket. But now there were additional pencil marks on the walls, more writing covering larger sections of the padded surface. I stepped closer to read them. They were intake notes. Psychiatric assessment documentation, written in small, precise handwriting that looked disturbingly like my own. Patient presence with disorganized speech and paranoid ideation. Denies suicidal intent but expresses belief that she is being replaced. Reports seeing another version of herself conducting interviews she does not remember. I felt something cold move through my chest. I pulled out my tablet and opened the patient chart system. The 12th chart was back. Novak, quiet room 3. But now it wasn't just a basic admission entry, it was a complete psychiatric file, 53 pages of documentation spanning 3 months. All of it written in my standard assessment format. All of it signed with my credentials. I opened the first entry, dated 3 months before I'd noticed any discrepancy. Initial interview conducted at 23:45. Patient admitted voluntarily following concerns expressed by family regarding memory loss and identity confusion. Patient reports increasing episodes of dissociation and lost time. Denies substance use. Reports finding documentation of activities she does not remember performing. Mental status exam reveals alert and oriented patient with intact memory for remote events but significant gaps in recent memory. The interview notes were thorough, detailed exactly the kind of assessment I would conduct. They included direct quotes from the patient that felt genuine, observations about affect and behavior that matched my clinical style. But I had no memory of writing them. I scrolled through the subsequent entries: daily assessments, medication adjustments, therapy session notes, incident reports. 3 months of continuous documentation for a patient in a room that had been out of service for 8 years, written by a version of me that I couldn't remember being. The most recent entry was dated that night, time-stamped 4:15 a.m., 2 minutes before the intercom call. Patient increasingly resistant to accepting diagnosis, continues to insist she is not the patient but rather the clinician. Has begun writing her own assessment notes on the walls, attempting to document her version of events. Delusion remains fixed. Recommend continued observation. I turned slowly to look at the walls again. Among the pencil marks, I could now distinguish 2 different sets of handwriting. One was neat and clinical, my assessment notes documenting a patient named Novak. The other was rougher, more urgent, and it repeated the same phrases over and over. I am the nurse. I conduct the interviews. This is not my room. I am not the patient. Both sets of handwriting were mine. I backed out of the room carefully, forcing my breathing to remain steady. I returned to the nurse's station and pulled up the hospital's employment records. I searched for my own personnel file. Hire date, March 14th, 7 years ago. Position, psychiatric intake nurse. Unit, 2nd floor behavioral health. Everything matched my memory. But when I opened the detailed employment history, I found a note flagged for supervisor review dated 3 months ago. Employee has begun exhibiting signs of confusion regarding role and responsibilities. Has been found in unauthorized areas conducting intake interviews with individuals not in the patient database. Recommends psychiatric evaluation and possible administrative leave. I had no memory of any such evaluation or concerns about my performance. I accessed my own documentation history, the record of all patient charts I'd created or modified during my employment. The list was extensive, thousands of entries spanning years. But when I filtered for the past 3 months, I found 2 distinct patterns of documentation. One set matched my conscious memory. Assessments conducted at the nurse's station, in interview rooms, in patient rooms. Normal locations, normal circumstances. The other set showed all assessments conducted in the same location, Quiet Room 3. Hundreds of entries, all for the same patient Novak, documenting interviews I didn't remember, conversations I'd never had, a progressive psychiatric deterioration I'd never witnessed. According to these records, I'd been spending hours each shift in Quiet Room 3 interviewing the same patient repeatedly, documenting her declining mental status, her increasing paranoia, her fixed delusion that she was actually the nurse and I was the patient. The intercom crackled again. My voice, but strained now, less professional. Someone is in my room, someone wearing my ID badge. She's reading my notes. She's trying to take my place. Helen didn't look up from her charting. I walked back to Quiet Room 3. The door was open now, though I'd closed it. Inside, sitting on the mattress, was a figure in nursing scrubs identical to mine. Same height, same dark hair, same ID badge. She was writing on the wall with a pencil stub, her movements quick and anxious. When she heard me enter, she turned. Her face was my face, but worn with exhaustion and fear. "You're not supposed to be here," she said. "This is my assessment. I'm conducting the interview." "I'm the intake nurse," I said carefully, employing the calm tone I used with delusional patients. "You're in a quiet room. You're receiving treatment." "No." She stood, backing against the wall. "I've been here for 3 months trying to make people understand. I'm Jenna Holloway. I work psychiatric intake. But every time I try to leave this room, I find myself back here. And every time I try to document what's happening, someone who looks like me tells me I'm the patient. I could see the walls now in full detail. One side documented a progressive psychiatric decline, my neat clinical notes describing a patient's deteriorating reality testing. The other side documented a nightmare of involuntary confinement, desperate attempts to prove identity, to assert professional credentials, to make someone understand that a mistake had been made. Both were written in my handwriting. Both were signed with my name. The interviews aren't real, I said, though I wasn't certain anymore which one of us I was trying to convince. The patient doesn't exist. I exist, she said. I'm here. I've been here every night conducting assessments, documenting cases, doing my job. But the unit keeps telling me I'm the one being assessed. I looked at my tablet. The chart for Novak, Quiet Room 3, was open. The most recent entry, time-stamped 4:47 a.m., was updating in real time as we spoke, documenting this conversation from a clinical perspective I hadn't consciously adopted. Patient confronted with clinical staff. Continues to insist on alternative identity. When presented with documentation of her admission and treatment, she claims the records describe the clinician rather than herself. Projection and identity confusion remain primary symptoms. I hadn't written those words, but they appeared in my standard format, under my credentials, in an assessment style I recognized as my own. The other Jenna watched me read the tablet. You see it now, don't you? The way the documentation changes depending on which side of the door you're standing on. I closed the chart. I put the tablet away. I walked out of Quiet Room 3 and locked the door behind me. The observation window was no longer covered. Through the glass, I could see her standing in the center of the room, watching me with an expression of resignation that felt disturbingly familiar. I returned to the nurse's station and completed the rest of my shift. I conducted my scheduled assessments. I documented everything properly. I didn't mention Quiet Room 3 to anyone, but when I checked the patient census before leaving at 7 a.m., there were 12 names on my list. The 12th assigned to Quiet Room 3. And when I pulled up that chart to review the night's documentation, I found my notes from every interaction, every assessment, every observation, including detailed entries about a patient who insisted she was the nurse, who believed she was conducting the interviews rather than being interviewed, who showed no insight into her deteriorating condition. I logged out. I gathered my belongings. I walked to the elevator. Behind me, very faint, I heard the intercom crackle one more time. My voice, tired and resigned. Night shift complete. All assessments documented. Patient in Quiet Room 3 remains stable for observation. Same plan for next shift. I don't know which version of me made that announcement. I've continued working intake since that night. The shifts proceed normally. I conduct my interviews, complete my assessments, document my observations. But I've stopped checking whether Quiet Room 3 is listed as occupied, because the answer changes depending on when I look and which system I check. Some nights, I'm certain I'm the nurse. Other nights, usually very late when the unit is quiet and I'm alone with my documentation, I notice that my notes describe events I'm not certain I experienced, conversations with patients I don't clearly remember meeting, hours spent in a room I know I didn't enter. The interviews continue. The documentation grows. And I've learned not to ask too carefully which role I'm actually performing, because the answer might depend on which side of the observation window I'm standing on when I check. Story 4. The post-op nurse's missing vitals. At exactly 2 a.m., his vitals disappeared. Heart rate, blood pressure, oxygen saturation, all flat-lined on the monitor. I rushed to his bedside, expecting a code. He was warm, breathing, talking to me with perfect clarity. "I'm fine," he said. "This happens every hour." Then at 2:01, the numbers reappeared. Normal sinus rhythm. 1:18:72, 98% saturation, as if the minute hadn't happened. When I checked his surgical history to report the malfunction, I found the operation he'd undergone, a routine gallbladder removal, was logged as canceled due to patient death 4 years before I met him. I'd worked post-operative recovery for 9 years at the time of the incident, all of it in the surgical step-down unit at St. Catherine's Medical Center. The unit handled the transition period between intensive post-operative care and general surgical floor management. Patients stable enough to leave the ICU but still requiring continuous monitoring and frequent assessment. It was detail-oriented work that suited my temperament. Vital sign monitoring, pain management, surgical site assessment, early complication detection. The unit ran on 12-hour shifts with a typical patient ratio of 4:1 on nights. I preferred night shift for its relative calm, the way it allowed for more thorough patient interaction without the constant interruptions of day shift procedures and physician rounds. The patient who would unravel my understanding of the unit arrived on a Wednesday evening in mid-November. I received report from the day nurse at 7 p.m. Malcolm Driscoll, 63 years old. Post-operative day 1 following laparoscopic cholecystectomy. Routine gallbladder removal, no complications during surgery, stable throughout the day. Expected discharge within 48 hours. Standard case. I introduced myself during evening rounds. Driscoll was awake, alert, conversational. He reported his pain level as 3 out of 10, well controlled with scheduled medications. His surgical sites looked clean, no signs of infection or excessive bleeding. His vitals were stable, heart rate 76, blood pressure 124/78, oxygen saturation 97% on room air. Everything unremarkable. "How are you feeling about the surgery?" I asked, completing my initial assessment. "Relieved to have it done," he said. "I've been putting it off for years. Probably should have done it sooner. Recovery usually goes smoothly for this procedure. You should be back to normal activities within a few weeks." He smiled faintly. "That's what they tell me." I continued my rounds to my other 3 patients, all recovering from various surgical procedures: hip replacement, hernia repair, thyroid removal. All stable, all progressing as expected. I settled into the rhythm of the shift. Hourly vital checks, medication passes at scheduled intervals, documentation of intake and output, pain assessments every 2 hours. At 10 p.m. during my routine vital sign check, I noticed the first anomaly. Driscoll's monitor showed normal readings at 9:58 p.m. When I entered his room at 10:00 p.m. to perform the manual check, the monitor displayed flat lines across all parameters. Heart rate, 0, blood pressure, turdu, oxygen saturation. I moved quickly to his bedside, expecting to find him in distress or the monitor leads disconnected. He was lying calmly in bed, reading a magazine by the overhead light, breathing normally. His skin was warm to the touch. I could feel a strong, steady pulse at his radial artery. "Mr. Driscoll, how are you feeling?" He looked up from the magazine. "Fine. Why?" "Your monitor is showing some unusual readings. I'm going to check your blood pressure manually." I wrapped the cuff around his arm and inflated it, watching the gauge carefully. Blood pressure 122/76, heart rate 74. I checked his oxygen saturation with a finger probe. 96%, all normal, all completely contradicted by the monitor, which still showed flat lines. I checked the lead connections, all secure. I reset the monitor. The flat lines persisted. "Has this happened before?" I asked. Driscoll glanced at the monitor with what seemed like weary recognition. "Every hour, you'll see." Before I could ask what he meant, the monitor flickered. At exactly 10:01 p.m., the vital signs reappeared. Heart rate 74, blood pressure 122/76, oxygen saturation 96%, the same values I'd just obtained manually, as if the minute of absent data had never occurred. I documented the incident and reported it to the charge nurse, who arranged for a biomedical technician to check the equipment. The tech arrived within 30 minutes, ran diagnostics on the monitor, replaced the leads, tested the connections. Everything checked out as functioning normally. "Equipment's fine," the tech said, "probably just a glitch. Call us if it happens again." At 11 p.m. during my next hourly check, the vitals disappeared again. Exactly at 11 p.m., all parameters flatlined. Driscoll remained stable, warm, breathing, awake. At 11:01 p.m., the numbers returned, showing normal values. The pattern repeated at midnight, at 1 a.m., at 2 a.m. Each time, precisely at the top of the hour, his vital signs would vanish from the monitor for exactly 60 seconds, while Driscoll remained physiologically stable and completely unbothered by the phenomenon. "This doesn't concern you?" I asked during the 2 a.m. episode, performing yet another manual vital check while the monitor showed him as clinically dead. "It used to," he said calmly. "I've gotten used to it." "How long has this been happening?" He paused, seeming to calculate. "Since the surgery, I think. Time gets a bit unclear." "This surgery yesterday?" "Yes, or I suppose it depends on how you count." I checked his chart more carefully, pulling up his complete medical history. Malcolm Driscoll, admitted for laparoscopic cholecystectomy. Surgery performed on November 12th, expected discharge November 14th. Everything consistent with what I'd been told during report. But when I scrolled further back in his surgical history, I found an earlier entry. Same procedure, laparoscopic cholecystectomy. Same surgeon, scheduled for November 12th. 4 years earlier, the status of that earlier surgery. Canceled. Patient mortality. I read the note several times, trying to make sense of it. According to the record, Driscoll had been scheduled for gallbladder removal 4 years ago, but died before the procedure could be performed. Cause of death listed as intraoperative cardiac arrest during anesthesia induction. That couldn't be correct. Driscoll was alive, recovering in my care, clearly post-operative from a successful surgery. I checked his admission date for the current stay. November 11th, 2 days ago. Surgery date, November 12th. Today was November 13th. I checked the calendar on my phone to confirm. November 13th. But when I looked at the timestamp on Driscoll's monitor, the small date-time display in the corner of the screen, it read November 12th, and the time was cycling in a strange pattern. During the minute when his vitals disappeared, the timestamp would freeze. When the vitals returned, the time would jump forward, skipping the missing minute entirely, as though that 60-second interval didn't exist. At 3 a.m., when the vitals vanished again, I watched Driscoll carefully. He was awake, watching me back with an expression of patient resignation. "What happens during this minute?" I asked. "The minute when the monitor can't detect you?" "I'm not entirely sure," he said. "Sometimes I feel like I'm somewhere else. The recovery room maybe, or still in the OR. It's hard to describe." "Do you remember the surgery? Which one?" The question settled over me with uncomfortable weight. "How many have you had?" "I'm not certain anymore. They tend to blend together." I performed the manual vital check. Blood pressure normal, heart rate normal, temperature normal. He was physiologically present, alive, stable. But according to the monitor, for that 1 minute each hour, he ceased to exist in any measurable way. At 3:01 a.m., the vitals returned. I excused myself and returned to the nurse's station. I pulled up the surgical schedule from 4 years ago, finding the original entry for Driscoll's canceled procedure. The notes were detailed. Patient brought to OR. Anesthesia induction begun. Unexpected cardiac arrest. Unsuccessful resuscitation. Time of death called at 10:47 a.m. But there was an addendum, added several hours later by a different physician. Autopsy declined by family. Body released to funeral home. Surgical equipment malfunction under investigation. Monitor failed to detect vital signs during critical period, delaying recognition of patient distress. The monitor had failed. 4 years ago, the same kind of failure. Vital signs undetectable at crucial moments. I checked Driscoll's current room assignment. Room 512, bed A. I checked the room assignment from 4 years ago. Same room, same bed. I walked back to his room. He was awake, still reading. The monitor above his bed displaying steady, normal vital signs. 3:15 a.m. Between the hourly anomalies. Mr. Driscoll, do you know what year it is? He looked at me with an expression that might have been sympathy. That's a complicated question here. Here? In the hospital? In this room specifically. Time doesn't work quite right in room 512. Not since the equipment malfunction. 4 years ago. Has it been 4 years? He seemed genuinely uncertain. It feels much shorter. I keep waking up post-op, keep going through recovery, keep getting ready for discharge, but I never quite get there. The monitor above his bed showed 3:28 a.m. Normal vitals. Stable patient. You died during that surgery, I said quietly. 4 years ago, during anesthesia induction. Yes, I remember that, the feeling of going under, then nothing, then waking up here in recovery, except I wake up here every time in this bed. In this room. And every hour for 1 minute I'm back in the OR and the monitors can't find me because I'm not quite there anymore. At 4 a.m. the vitals disappeared again. I watched the monitor flatline while Driscoll lay calmly in bed, breathing steadily, eyes open, physiologically impossible. During this minute, I asked him, "Where do you go?" "I'm on the table. They're trying to resuscitate me. I can hear them calling for the crash cart, can feel them doing compressions. But I also know I'm here, in this bed, having already recovered from a surgery that never actually succeeded. I exist in both places, neither. The minute doesn't belong to either timeline, so the monitors can't track it." At 4:01 a.m. his vitals returned. Heart rate 76, blood pressure 124/78, oxygen saturation 97%, the same stable values he'd shown all night. I completed my shift in a state of careful documentation, recording each hourly anomaly, each manual vital check that contradicted the monitor's inability to detect him. I noted his stable recovery, his normal post-operative progression, his expected discharge timeline. At 6:30 a.m. I gave report to the day shift nurse. Driscoll in 512 is post-op day 2, cholecystectomy, stable throughout the night. He's having some monitor issues, vitals dropping out every hour on the hour for about a minute. Equipment has been checked, appears to be functioning normally. Patient remains stable during episodes. The day nurse nodded, making notes. Probably interference from something. I'll keep an eye on it. I gathered my belongings and prepared to leave. Before I did, I checked Driscoll's chart one more time. Discharge plan, November 14th. Pending stable vitals and surgical site assessment. But I noticed the discharge date had been the same in every note I'd read. November 14th. Always tomorrow. Never today. I haven't worked with Driscoll since that shift. The schedule rotated me to different patient assignments. But I've asked other nurses about room 512. Most reported as unremarkable, just another post-surgical recovery room. A few mention occasional equipment glitches, monitors that lose signal for brief periods, vitals that disappear and reappear without explanation. One nurse, who'd worked the unit longer than anyone, told me that room 512 had the highest turnover of any room on the floor. "Patients do fine," she said. "They just never seem to actually discharge. They get close, then something happens. A minor complication, a slight fever, a need for one more day of observation." Eventually, they transfer to a different room and then they discharge normally, but never from 512 directly. I pulled the long-term records for that room. Over the past 4 years, 73 patients had been assigned to room 512, bed A. All post-operative, all stable, all scheduled for discharge within 2 to 3 days. None had discharged directly from that bed. All had required transfer to different rooms first, and the average length of stay in room 512 before transfer, 11 days, far longer than typical post-operative recovery for the procedures they'd undergone. I checked Driscoll's current status, still admitted, still in room 512, still post-operative day 2, though weeks had passed since I'd cared for him. Still scheduled for discharge tomorrow, pending stable vitals. The monitors, I've learned, are working exactly as designed. They track vital signs in real time, displaying the physiological status of the patient under observation. The problem is that some patients exist in a timeline the monitors can't fully access, stuck in the minute between life and death, between the OR and recovery, in a space where the equipment failed once and continues failing in an endless loop of undetected absence. And every hour, for 60 seconds, the monitors show the truth. There's no one there to measure because the patient never left the table, never survived the induction, never made it past the moment when the equipment stopped working, and no one noticed in time. Story 5. The pediatric ward nurse and the drifting crib. I first noticed the crib outside room 318 during my 11 p.m. rounds. White metal frame, standard hospital issue, positioned in the hallway with no visible reason for being there. I checked the room assignments. No infant admitted to that room. I moved the crib to storage. At 1 a.m. I found it outside room 322. I hadn't heard it move. The wheels left no marks on the polished linoleum. When I checked the linen, I saw a small indentation in the mattress, as if something infant-sized had recently been lying there. The blanket was warm. I'd been a pediatric nurse for 14 years when I took the night shift position at County Children's Hospital, working the medical surgical floor that handled everything from post-operative care to chronic illness management for patients ranging from newborns to adolescents. The unit had 24 beds organized along 2 parallel corridors, with a central nurses' station positioned to provide visual oversight of both hallways. Night shift on pediatrics had its own particular rhythm, different from adult units. Children's sleep patterns were less predictable. Parents often stayed overnight in the rooms, and the baseline noise level, even during quiet hours, included the occasional cry or call that required immediate assessment to determine if it indicated genuine distress or simple nighttime restlessness. I developed an instinct for distinguishing between the two, for knowing which sounds required urgent response and which were part of the normal background of a children's ward. The crib first appeared on a Tuesday in early December. I began my shift at 7 p.m. with the usual handoff report, receiving updates on the 16 patients currently admitted to the floor. None were infants young enough to require a crib rather than a standard pediatric bed. Our youngest patient that night was a 2-year-old recovering from appendicitis, assigned to room 307, sleeping in a regular toddler bed with side rails. At 11 p.m., during my first complete rounds after the unit had settled for the night, I found a crib positioned in the hallway outside room 318. It was a standard hospital infant crib, white metal frame, clear plastic bassinet, thin mattress with pale blue sheets, a white cellular blanket folded at the foot, the kind we used for newborns and young infants, equipped with wheels for easy transport. Room 318 housed a 7-year-old being treated for pneumonia. No infant, no reason for a crib to be there. I checked the crib carefully. It appeared to be in good condition, clean, ready for use. The wheels were unlocked, meaning it could be moved easily. But I hadn't seen anyone transport it to that location, and none of the other nurses had mentioned moving equipment. I wheeled the crib to the supply room at the end of the corridor and left it with the other spare cribs we kept for unexpected infant admissions. I returned to the nurse's station and made a note to ask the evening shift if they'd moved it for some reason. At 1 a.m. during my next full round, I found the crib outside room 322. I stopped in the hallway staring at it. I'd just been in the supply room 30 minutes earlier to retrieve medication from the locked cabinet. The crib had been there, positioned against the wall with 3 others. Now it stood in the hallway, wheels locked, positioned precisely in the center of the corridor as though someone had placed it with care. I walked the length of both hallways. All the other staff were accounted for. One nurse was in a patient room administering medication. Another was in the break room. The unit clerk was at the front desk. None had mentioned moving a crib. The parents staying overnight with their children were all in their respective rooms. I examined the crib more closely this time. The mattress showed a small indentation, the kind that forms when weight has been resting on it. I touched the blanket. It was warm, distinctly warmer than room temperature, as though body heat had recently transferred to it. I checked room 322. The room housed a 10-year-old recovering from a bone marrow biopsy. She was asleep, her mother dozing in the reclining chair beside the bed. No infant, no explanation for the crib. I moved it back to the supply room, making certain to lock the wheels this time, positioning it in the far corner against the wall. I closed the supply room door firmly. At 3 a.m., I found the crib outside room 309. This time I didn't move it immediately. Instead, I watched it. I stood at the nurse's station with a clear view down the corridor to where the crib sat, positioned in the hallway, wheels locked, exactly centered between the doorways of rooms 308 and 310. I watched for 20 minutes. The crib didn't move, but I had the distinct impression that it was occupied. Not visibly, but in some way I couldn't articulate. The blanket shifted slightly as though disturbed by breathing. The mattress seemed to compress and release in a gentle rhythm. I walked to the crib slowly. As I approached, I heard a sound, very faint, barely audible, the soft, peaceful breathing of a sleeping infant. I looked into the crib, empty, just the mattress, the sheets, the blanket. But the sound of breathing continued, steady and calm, emanating from the apparently empty bassinet. I reached out to touch the mattress. The indentation deepened under my hand as though I were pressing down on something solid, something with weight and warmth. But my hand met only the mattress surface. Nothing visible, nothing I could identify. I pulled my hand back. The indentation remained. I checked my patient roster again, specifically looking for any infant admissions I might have missed during shift change. Nothing. I checked the emergency department's pending admissions. No infants in transit. I checked labor and delivery in case a newborn had been sent to our floor for specialized care. No transfers. I left the crib where it was and returned to the nurse's station. I pulled up the hospital's equipment tracking system, which logged the movement and usage of all major medical devices, including cribs. According to the system, all 7 pediatric cribs were currently in the supply room, unused, with no movement logged for the past 72 hours. But I could see the crib in the hallway. I could hear the breathing. At 4:30 a.m., I walked past the crib's location on my way to respond to a call light in room 315. The crib had moved again, now positioned outside room 304. The breathing sound had grown slightly louder, more pronounced, and beneath the blanket, I could see the clear shape of something small, the outline of an infant lying on its side, knees drawn up, one arm extended. I stopped walking. I stared at the shape beneath the blanket. It was impossible to deny. The blanket draped over a form, rising and falling with breath, shaped by the presence of a body I couldn't see. I pulled back the blanket slowly. Nothing. Empty mattress. But the indentation was pronounced now, deeply compressed. The sheets wrinkled as though someone had been lying there for hours. And the warmth was undeniable. The entire mattress was warm, the temperature of skin. I covered the space again with the blanket and stepped back. At 5 a.m. during medication rounds, I found the crib outside room 317. I developed a pattern of checking for it every time I moved through the corridors. It was always in a different location, always positioned with the same careful precision in the center of the hallway. Always apparently occupied by something I couldn't see but could increasingly sense. At 6 a.m., as the night shift approached its end and the early morning routine of the hospital began to stir, I found the crib outside room 311. This time there was something new, a chart hanging from the side rail. A patient chart in the standard blue folder we used for pediatric admissions. I lifted the chart with hands that had started trembling slightly from exhaustion or unease. I opened it. The patient name field was blank. Birth date, December 8th. That was today's date. Admission time, 23:15. That was when I'd first seen the crib during my 11 p.m. rounds. The chart contained a full intake assessment, documenting an infant admission, vitals, measurements, weight, length. All the fields were filled in with neat, precise handwriting that looked disturbingly familiar. It was my handwriting, my documentation style, my standard abbreviations, my signature at the bottom of each page. But I had no memory of writing any of it. I read through the assessment notes. Infant admitted for observation, appears peaceful, breathing regular. Parents declined to stay overnight. Patient assigned to temporary location pending room assignment. Parents declined to stay. In 14 years of pediatric nursing, I'd almost never encountered parents who wouldn't stay with an admitted infant. It was virtually unheard of. I turned to the next page. Hourly vital checks, each time stamped at the top of each hour. 12 a.m., 1 a.m., 2 a.m., 3 a.m., 4 a.m., 5 a.m. All documented in my handwriting. Heart rate, respiratory rate, temperature, all within normal ranges for a newborn. All signed with my credentials. I looked at the crib. The shape beneath the blanket was fully formed now, unmistakable. An infant, sleeping peacefully, visible only as the space it occupied beneath the linen. At 6:30 a.m., as I prepared to give report to the day shift, I checked the crib one more time. It had moved to the supply room, positioned with the other cribs against the wall. The chart was still attached to the side rail. The blanket still showed the form of a sleeping infant. I gave report on my 16 assigned patients, describing their conditions, overnight events, pending care needs. I didn't mention the crib. As I gathered my belongings to leave, the day shift nurse, a woman named Patricia who'd worked pediatrics for over 20 years, approached me quietly. "Did you see the crib last night?" I felt relief and dread in equal measure. "You know about it?" "It's been appearing on night shift for about 3 months now," Patricia said, her voice low. "Different locations every time anyone checks. Always empty, but always occupied. Some of the night nurses refuse to acknowledge it. They document around it, work around it, pretend it's not there." "What is it?" Patricia shook her head. "We don't know. But about 3 months ago, there was an infant admitted for routine observation. Sudden infant death syndrome risk factors, so the family brought her in to be monitored overnight. The baby was placed in one of our cribs in room 313. During the night shift, the assigned nurse got busy with another patient emergency and didn't complete the hourly checks on time. When she finally got to the room at 4 a.m., the crib was empty, the baby was missing." I felt my chest tighten. Missing? They found her an hour later in a different room, still in a crib, still sleeping peacefully. No explanation for how she got there. The crib had been moved, the baby transported without anyone seeing or hearing it happen. The family was terrified. They left AMA as soon as the sun came up. And the crib. Since then it drifts, every night shift, moving through the unit, occupied by something that needs monitoring, something that requires hourly checks. And somehow whoever works night shift ends up documenting those checks, even if they don't remember doing them. I pulled out my phone and checked my documentation from the night. In addition to my 16 assigned patients, I found a 17th chart, the infant with no name, admitted to no room, assigned to a crib that officially didn't exist. Every hour I'd documented vital signs. Every hour I'd signed my name confirming the assessment. I had no memory of writing any of it. Patricia put a hand on my shoulder. It's not harmful. The baby, whatever it is, just needs to be watched. Needs someone to check, to document, to confirm it's still there. Most night nurses learn to accept it eventually. You'll see it again tonight if you're scheduled. I was scheduled. That night, the crib appeared first outside room 320 during my 11 p.m. rounds. The chart was already attached, dated for that evening, and with my handwriting documenting the admission assessment I didn't remember conducting. Throughout the shift, I found myself standing beside the crib at the top of each hour. Midnight, 1 a.m., 2 a.m., performing vital checks on the invisible infant, feeling for the warmth of skin I couldn't see, listening for the breathing I could clearly hear, documenting normal findings in a chart for a patient who existed only in the space between what was visible and what required care. By my third week on the night shift, I stopped questioning it. The crib drifted through the unit. I performed my hourly assessments. I documented everything properly. The infant beneath the blanket remained stable, peaceful, requiring nothing more than the confirmation that someone was watching, someone was checking, someone remembered to look. The other night, nurses and I never speak about it directly during shift change. But we all know. We all document the same patient, sign the same charts, provide the same care to the same invisible presence that moves through our corridors, needing only the assurance that it hasn't been forgotten. Sometimes, very late in the shift when the unit is particularly quiet, I stand beside the drifting crib and wonder if this is how all unwitnessed deaths persist, as patterns of care that continue indefinitely, invisible patients requiring eternal observation, documented in charts that prove someone was watching, someone was there, even if they arrived just minutes too late to change what had already happened. The crib is always occupied. The checks are always completed. The documentation proves that someone is always paying attention now, even if no one was paying attention then, in the moment that mattered, in the hour when a quick check might have meant the difference between a sleeping infant and an empty crib that drifts through the hallways, forever seeking the care that came too late. Story 6. The hospice night nurse's final conversation. His last words were spoken at 11:43 p.m. The water will stop running on Thursday. You should call someone before then. He died peacefully at 11:51 p.m. I documented the time, notified the family, completed the post-mortem care. But when I reviewed my notes the next morning, I found an additional page I didn't remember writing. 12:47 a.m. Patient reports feeling more comfortable. Requests conversation continue tomorrow night. His bed was empty. The body had been released to the funeral home hours earlier. Yet my handwriting insisted our conversations were ongoing. I'd worked in hospice care for 16 years before I encountered Thomas Brennan, spending most of that time on the night shift at Riverside Hospice, a 40-bed facility specializing in end-of-life care for patients with terminal diagnoses. The work required a particular emotional equilibrium, the ability to provide comfort and dignity to dying patients while maintaining enough professional distance to avoid being consumed by the constant presence of death. I'd developed what I thought was an appropriate balance, I was attentive, compassionate, skilled at pain management and symptom control. I sat with patients during their final hours when family couldn't be present, held hands, listened to last words, and I'd learned to let go when each patient passed, to complete the necessary documentation and move forward to the next person requiring care. Thomas Brennan was admitted to Riverside on a Monday evening in late January, transferred from the hospital's oncology ward after his physician determined that curative treatment was no longer viable. Stage 4 pancreatic cancer, metastatic to liver and lungs, prognosis of days to weeks. He was 71 years old, a retired civil engineer, calm and articulate despite his deteriorating condition. I met him during my initial rounds at 8 p.m. He was settled in room 12, a single occupancy room with a window overlooking the facility's garden. His daughter had stayed through the admission process but left around 7:30, planning to return the following morning. Brennan was awake, slightly short of breath, but comfortable on low-flow oxygen. Pain well controlled with a continuous morphine infusion. "Good evening, Mr. Brennan," I said, checking his IV site and adjusting his pillows. "I'm Lauren, one of the night nurses. How are you feeling?" "Comfortable enough," he said, his voice steady despite the oxygen cannula. "Better than I expected, honestly." "That's good to hear. The goal here is to keep you comfortable. If anything changes, pain, breathing difficulty, anxiety, you let me know immediately." "I will." He paused, studying my face with an intensity that felt unusual for someone in his condition. "You've done this a long time, haven't you? Sitting with people at the end. 16 years. Then you know what to expect, what it looks like when someone is close." "Generally, yes. How close am I?" I'd learned to be honest about these questions while remaining compassionate. "Your physician estimated days to weeks. That's the most accurate answer I can give you. Everyone's timeline is different." He nodded slowly. "Days, I think, not weeks. I can feel it." He looked toward the window, though it was too dark to see the garden. "There are things I need to tell people, practical things. My daughter will need to know about the water main at my house. It's been making noise, probably needs repair before it fails. And there's a leak in the roof over the back bedroom that should be addressed before spring. You should write that down for her if you're able, or I can help you make a list." "I will." But he seemed distracted, as though listening to something I couldn't hear. "The water will stop running on Thursday. She should call someone before then." It was Monday night. Thursday was 3 days away. The specificity seemed unusual, but I'd heard dying patients make all kinds of predictions and statements. Some were metaphorical, some were confused, some were startlingly accurate. I made a note to mention it to his daughter during her next visit. Over the following hours, I checked on Brennan every 30 to 40 minutes, monitoring his comfort level and vital signs. He remained stable, drifting in and out of sleep, occasionally waking to ask for ice chips or to shift position. Our conversations during these checks were brief and practical. Pain level assessments, medication timing, basic comfort needs. At 11:30 p.m., when I entered for a routine check, his breathing had changed, shallower, more irregular. His oxygen saturation had dropped slightly despite the supplemental oxygen. These were signs I recognized, the body beginning its final decline. I sat in the chair beside his bed. "Mr. Brennan, can you hear me?" His eyes opened. "Yes, it's happening now, isn't it? Your breathing has changed. You're getting close. Would you like me to call your daughter?" "No. Let her sleep. I don't want her to remember this part." He took a labored breath. "Stay, though, if you can." "Of course." We sat in silence for several minutes. His breathing continued to decline, each breath requiring more visible effort. At 11:43 p.m., he spoke again, his voice barely audible. The water will stop running on Thursday. She should call someone before then. A pause, another difficult breath. Tell her the roof needs repair. The leak will get worse with the spring rain. I'll make sure she knows. Thank you. His eyes closed. His breathing became more sporadic, periods of apnea lengthening between breaths. At 11:51 p.m., Thomas Brennan stopped breathing. I waited, watching for any resumption, but there was none. I checked for a pulse. None. I documented the time of death and began the necessary post-mortem procedures, calling the physician for official pronouncement, notifying the funeral home, preparing the body, gathering his belongings for family pickup. I completed all required documentation by 1:15 a.m., noting his final words, his peaceful passing, the absence of distress. I moved on to my other patients, continuing the night's routine. At 6 a.m., as I prepared to give report to the day shift, I reviewed my documentation one final time to ensure everything was complete and accurate. I opened Brennan's file to verify the time of death and final notes. The file showed entries I didn't remember writing. 12:47 a.m. Patient reports feeling more comfortable, pain well controlled, requests conversation continue tomorrow night. 1:33 a.m. Patient awake and alert, discussed concerns about home maintenance issues, advised family contact regarding water main repair. 2:18 a.m. Patient resting peacefully, vital signs stable. Each entry was in my handwriting using my standard documentation format, signed with my credentials. But Thomas Brennan had died at 11:51 p.m. I'd pronounced him dead, prepared his body, sent him to the funeral home. These entries were impossible. I checked the bed census. Room 12 was listed as vacant, ready for cleaning and new admission. I walked to room 12. The bed was stripped, the room empty, awaiting the morning cleaning staff. No patient, no equipment. The window looked out on the garden, barely visible in the pre-dawn light. But on the bedside table I found a notepad with writing on it. My handwriting. A list: water main repair, call before Thursday roof leak, back bedroom, address before spring furnace filter needs replacement, check foundation, south wall, possible settling. I didn't remember writing this list, but the handwriting was unmistakably mine. I reported for my shift that evening with a sense of unease I couldn't fully articulate. Room 12 remained empty, no new admission scheduled. During my initial rounds, I avoided that end of the corridor, focusing on occupied rooms attending to living patients with immediate needs. At 11:43 p.m., exactly 24 hours after Brennan's final words, I found myself standing outside room 12 without consciously deciding to walk there. The door was closed. I opened it slowly. The room appeared empty, bed stripped, surfaces clean. But when I stepped inside, I heard breathing. Slow, labored, requiring effort. The oxygen concentrator mounted on the wall activated, though nothing was connected to it. I approached the bed. The mattress showed a clear indentation, the impression of a body lying in the position Brennan had occupied during his final hours. The blanket I'd removed during post-mortem care was back, draped over the empty bed, rising and falling with invisible breath. "Mr. Brennan?" I said quietly. The breathing paused. Then, very faint, I heard his voice. "Lauren, you came back." "I'm here. What do you need?" "To finish our conversation, there are more things Sarah needs to know. The furnace filter should be changed monthly, but I've been negligent. And there's settling in the foundation along the south wall. She should have it inspected before it worsens." I pulled out my notepad and wrote down what he said, my hand moving automatically, documenting his words as I would for any patient providing important information. We talked for 20 minutes. He described maintenance issues with his house, financial accounts his daughter should know about, the location of important documents, Practical, detailed information delivered in the same calm, articulate manner he'd shown before death. When the conversation ended, I returned to the nurse's station and documented the interaction in his file, which had reappeared in the system active again, showing him as a current patient in room 12. This pattern continued for 6 consecutive nights. Each evening at 11:43 p.m., I would find myself drawn to room 12. Each time the room appeared empty but was clearly occupied by Brennan's presence. The indentation in the mattress, the sound of breathing, his voice providing additional details about matters he wanted his daughter to handle. And each time I documented our conversation, filling pages of notes that appeared in a patient file that should have been closed on the night of his death. On the 7th night, I brought his daughter Sarah to the hospice. I'd called her that afternoon saying I had information her father wanted her to know. I didn't explain how I'd obtained it. We sat in the family conference room while I went through the list. Pages of detailed notes about home maintenance, financial accounts, personal effects, people who should be contacted. Sarah listened with growing tears. "This is exactly like him," she said. "Practical to the end, worried about the house, about making sure I had everything I needed." She paused. "When did he tell you all this?" "He was only conscious for a few hours after admission." I chose my words carefully. "He's been communicating, making sure you have the information you need." Sarah wiped her eyes. "Thank you for listening, for writing it all down. He always needed to know things were handled properly." That Thursday, the day Brennan had mentioned, Sarah called the hospice to thank me. "The water main broke this morning," she said, "exactly like Dad predicted. If you hadn't told me, I wouldn't have had anyone on call. It could have flooded the whole basement. I'm glad the information was helpful. There's something else. I went through the house using your notes. Everything you listed was exactly right. The roof leak, the furnace filter, the foundation settling. Things I never would have known to check. It's like he's still here, still taking care of me." After that call, Brennan's nightly presence in room 12 diminished. I still found myself drawn to the room occasionally, still heard the faint sound of breathing, but the conversation stopped. The documentation entries I couldn't remember writing became less frequent. By the end of the month, room 12 was occupied by a new patient, and Brennan's file finally closed in the system, showing only the original death documentation from that first night. But periodically, usually late in my shift when the hospice is particularly quiet, I'll review my old files and find new entries, additional notes in my handwriting, documenting conversations with patients who died weeks or months earlier, providing information their families needed, continuing dialogues that apparently don't end simply because breathing stops. I've learned that some patients require more than one conversation to say everything that needs to be said. Their bodies may fail, their breathing may cease, but the need to communicate, to ensure loved ones are cared for, to finish the work of a lifetime, that persists. And so I document it. I write down their words, I make their lists, I pass along their messages. The files stay open longer than they should, filled with entries that span the boundary between life and death, because some conversations don't conclude neatly, don't finish with a final word in a documented time. They continue night after night, in rooms that appear empty but aren't, with patients whose presence persists in the careful notations I find in my handwriting each morning, proving that I listened, that I stayed, that I helped them finish what they needed to say. Story 7, the ER charge nurse's shadow triage. The patient appeared directly in Bay 4 at 2:17 a.m. Elderly woman, silent, staring at me with recognition, though I'd never seen her before. No triage bracelet, no registration in the system, no record of entering through the waiting room. When I checked the intake log, I found an entry in my handwriting time-stamped 2:03 a.m., 14 minutes before she appeared, documenting a complete triage assessment I had no memory of conducting. She knew my name. She knew details about my shift I hadn't told anyone. And when I asked how she'd arrived, she said, "You brought me through, the other entrance, don't you remember?" I'd served as an ER charge nurse for 12 years at the time, all of it at Metropolitan General, a Level 1 trauma center serving a metropolitan area of roughly 2 million people. The role required constant situational awareness, tracking patient flow, managing bed assignments, coordinating staff, anticipating surges, making rapid decisions about resource allocation during the controlled chaos that defined emergency medicine. Weekend night shifts were particularly demanding. Friday and Saturday nights brought predictable waves of trauma, intoxication, psychiatric crises, and acute medical emergencies that could overwhelm even a well-staffed department. I developed systems to manage the chaos, rigorous triage protocols, clear communication chains, efficient bed turnover, control the flow, anticipate the surge, maintain awareness. Those principles had served me well through countless shifts. The weekend in mid-February when the shadow triage began was unremarkable in its chaos. I arrived for my shift at 6:45 p.m. on Friday to an ER already operating at capacity. 24 treatment bays full, 12 patients in the waiting room, ambulances arriving every 15 to 20 minutes. Standard Friday night escalation. I assumed charge duties at 7 p.m., receiving report from the day charge nurse, reviewing the patient board, assessing acuity and expected disposition times. By 8 p.m., we'd moved 3 patients to the floor, discharged 5, and admitted 7 new ones. The flow was manageable if intense. Triage was managed by 2 experienced nurses working the intake area near the ambulance bay and main entrance. Every patient entering the ER, whether by ambulance or walk-in, passed through triage, received an assessment, got assigned an acuity level, and was registered in our tracking system before placement in a treatment bay or the waiting room. No one bypassed triage. The system didn't allow it. At 9:47 p.m., I noticed the first anomaly. I was reviewing the patient tracking board, a large electronic display showing every ER bed, current patient, acuity level, attending physician, and disposition status. Bay 7 showed a new patient, Marcus Whitfield, 52, chief complaint listed as chest pain. ESI Level 2 assigned to Dr. Patterson. I didn't remember receiving a new patient in Bay 7. I'd been monitoring bed assignments closely, directing incoming patients to open bays as space became available. Bay 7 had been occupied until approximately 9:30 when we discharged a patient with a sprained ankle. I'd planned to assign it to the next moderate acuity patient from the waiting room, but I hadn't yet made that assignment. I walked to Bay 7. A middle-aged man was lying on the gurney, EKG leads attached to his chest, oxygen cannula in place, IV started in his left arm. A nurse I didn't immediately recognize was drawing blood from the IV port. "Excuse me," I said. "I'm Lauren, charge nurse." "When did this patient arrive?" The nurse looked up. She was young, maybe mid-20s, with dark hair pulled back in a ponytail. I didn't recognize her, which was unusual. I knew every ER nurse on the regular staff rotation. Triage sent him back about 10 minutes ago. Possible MI. So I got him set up for the fast-track cardiac protocol. "Which triage nurse sent him?" She looked confused by the question. "You did? You brought him through yourself and gave me report." "I didn't bring anyone through. I've been at the charge desk managing assignments." The nurse's expression shifted to concern. "You walked him back from triage around 9:35, gave me his information, told me to treat him as a potential cardiac event. We've been following the protocol since then." I checked the tracking system on my phone. Marcus Whitfield's chart showed a triage time of 9:33 p.m., triaged by L. Garrison. My name, my credentials. I pulled up the full triage assessment. It was complete and thorough. Vital signs, chief complaint, medical history, current medications, pain level. All documented in the standard format I used when I occasionally covered triage during surge situations. The handwriting on the paper backup form matched mine. But I had been at the charge desk from 9:15 to 9:50, managing bed flow, coordinating with radiology about scan scheduling, talking to the supervisor about staffing for the overnight shift. I hadn't left the area. I hadn't conducted a triage assessment. I approached the patient. "Mr. Whitfield, can you tell me how you arrived at the ER tonight?" "I walked in through the main entrance," he said, slightly short of breath. "The nurse at the desk took my information, checked my blood pressure and pulse. Then the charge nurse, I think that was you, brought me back here pretty quickly because of the chest pain." "Can you describe the nurse who brought you back?" He looked at me with puzzlement. "You did. You told me your name was Lauren, that you were managing the ER tonight, and that we were going to get my heart checked out right away." I excused myself and returned to the triage desk. Both triage nurses were busy with incoming patients. I pulled aside the senior nurse, Rita, during a brief gap. "Did you triage a Marcus Whitfield about 20 minutes ago? Chest pain, middle-aged male?" Rita checked her log. "No. My last 3 were a pediatric fever, a laceration, and a GI complaint." "Why?" "He's in Base 7. The system shows I triaged him, but I don't remember doing it." Rita frowned. "You haven't been to triage tonight." "You've been at charge. Are you sure you're looking at the right patient?" I showed her the tracking system entry. "This shows me as the triaging nurse." "That's strange. Maybe a system glitch duplicated your credentials from a previous entry." I wanted to believe that explanation, but the paper backup form was in my handwriting, not a digital duplication, my actual handwriting. I returned to my charge duties, monitoring the board, managing flow. Over the next hour, 2 more patients appeared in treatment bays with the same pattern. No memory of their arrival, complete triage assessments with my credentials, patients who claimed I'd personally brought them from the waiting area. By midnight, I documented 6 patients I had no recollection of triaging, all showing complete intake assessments in my name, all claiming I'd conducted their triage and personally escorted them to treatment areas. At 1:15 a.m., I decided to review the security footage. I went to the security office and requested to see the camera feeds from the triage area and main ER corridor for the past several hours. The security officer pulled up the relevant footage, and we watched at double speed. I could see myself clearly on the charge desk camera, working continuously from 9:15 p.m. to the present, exactly as I remembered. But on the triage area camera, I saw something that made my chest tighten. A second version of me appeared periodically in the triage zone, walking patients through the assessment process, taking vital signs, documenting information, then escorting patients down the corridor to treatment bays. This version of me moved with the same efficiency and purpose as my conscious self, wearing an identical uniform, using the same body language and gestures I recognized as my own. "That's you, right?" the security officer asked, pointing at the figure on the triage camera. "You're covering triage during the surge?" "I'm supposed to be at the charge desk," I said, pointing at the other camera feed showing me in that location at the exact same timestamp. "How can I be in both places simultaneously?" The officer leaned closer to the screens. "Huh, that's weird. Must be a timestamp error or something." But he looked uncertain. I watched both feeds play in parallel. For every moment I was visible at the charge desk. The other version of me was conducting triage, assessing patients, documenting findings, moving people through the system with practiced efficiency. 2 versions operating in parallel, both performing critical nursing functions, both apparently real. At 2:03 a.m., I saw myself on the triage camera approach an elderly woman in the waiting room. I watched myself conduct a full assessment, document everything on the intake form, then lead her toward the treatment area. At 2:17 a.m., the same elderly woman appeared in Bay 4. I left the security office and walked to Bay 4. The woman was sitting upright on the gurney, silent, watching the doorway as though expecting me. She was in her 70s, thin, with gray hair and dark eyes that tracked my approach with unsettling recognition. "Hello," I said carefully. "I'm Lauren, the charge nurse. How are you feeling?" "You know how I'm feeling," she said quietly. "You already asked me during triage. You documented everything." She gestured to the chart hanging on the end of the bed. I picked up the chart. Complete triage assessment, timestamp 2:03 a.m., signed with my credentials. The handwriting was mine. The documentation included details I couldn't have known: her medical history, her current medications, the specific character of her presenting complaint. "What brought you to the ER tonight?" I asked. "You did," she said simply. "You brought me through the other entrance, the one parallel to this one, don't you remember?" "What other entrance?" She looked at me with something like sympathy. "The one where you work when you're not here. The triage area that runs alongside this one, processing the patients who arrive through different channels." I felt cold settle in my chest. "I don't understand." "You work both sides," she said. "Here, where you manage the conscious flow, the patients you see arrive, the cases you deliberately assess, and there, where you process the ones who slip through in the margins, the cases that don't register consciously but still require triage. That doesn't make sense." "You've been doing it for months," she continued calmly. "Every shift, you split your attention. Part of you manages the visible ER, the official flow. Part of you works the shadow triage, processing the patients who arrive through alternative channels, the ones who are already in critical states, who bypass normal entry because they don't have time for waiting rooms." I backed away slowly. "You need psychiatric evaluation. I'm going to have the doctor see you." "Check your documentation," she said. "All the patients you don't remember triaging, go back through your records, months of parallel work." I returned to the charge desk and pulled up my triage records for the past 3 months. The pattern was undeniable. Alongside my conscious documentation, the patients I remembered assessing, the cases I deliberately processed, were hundreds of additional entries. All in my name, all in my handwriting on the backup forms. All documenting complete assessments I had no memory of conducting. The patients triaged in these shadow entries had a pattern, all high acuity, all in critical or near critical states, all requiring immediate intervention. And according to follow-up notes, all had been treated successfully, stabilized, and either admitted or discharged in stable condition. I was saving lives I didn't remember encountering. At 3:30 a.m., during a brief lull in the chaos, I walked to the triage area. The 2 regular triage nurses were taking a quick break. I stood in the empty intake zone looking at the familiar setup, the assessment desk, the vital sign equipment, the doorway leading to the waiting room, the corridor leading to the treatment areas. Then I noticed something I'd never consciously registered before. There was a second corridor running parallel to the main treatment hallway, visible only from a specific angle. I walked toward it slowly. The corridor was identical to the main one, but quieter, dimmer. Treatment bays lined both sides, numbered with the same designations as the primary bays, but with a subtle difference. They seemed slightly out of phase, like viewing a reflection through water. I walked down this parallel corridor. Each bay was occupied. I recognized some of the patients, people I'd apparently triaged according to my shadow documentation, cases I had no conscious memory of assessing. They were receiving care from staff I didn't recognize, nurses and physicians who moved with competent efficiency but didn't acknowledge my presence. In Bay 4 of this shadow corridor, I found the elderly woman, now in exactly the same position as in the Bay 4 of the primary ER. She looked at me as I approached. "You're beginning to see it," she said. "The parallel system. The overflow processing that happens when conscious attention reaches capacity." "This isn't real," I said, though the words felt hollow. "It's as real as the other side. You work both. You always have, probably. But it's become more pronounced as the ER gets busier, as the surge intensifies. Your mind splits the load, processes the obvious cases consciously, handles the critical overflow unconsciously. Two triage systems, both running under your supervision, both bearing your signature." I returned to the primary ER corridor. Everything snapped back into sharp focus. The normal lighting, the familiar noise level, the staff I recognized. But when I looked over my shoulder, I could still see the parallel corridor operating in quiet efficiency, processing the patients who slipped through the margins of conscious awareness. For the rest of that shift and every shift since, I've worked both triage systems. The primary one I manage consciously, tracking patients, documenting assessments, coordinating flow. The shadow one operates in my peripheral awareness, processing the critical cases that arrive through channels I can't fully perceive, conducting assessments I won't remember, signing my name to documentation that appears in my handwriting without my conscious participation. The patient outcomes are excellent on both sides. Lives saved, conditions stabilized, appropriate care delivered. My performance reviews are outstanding. No one questions the parallel documentation because the results speak for themselves. But sometimes, late in a shift when exhaustion blurs the boundaries, I catch glimpses of myself in the shadow corridor, conducting a triage assessment with the same focused efficiency I bring to conscious work, documenting findings in my standard format, escorting patients to treatment bays that exist in the space between official beds. The ER operates on both levels now, and I'm the charge nurse for both, managing the flow I can see and the flow that runs parallel to visibility, signing my name to assessments conducted by a version of myself I'm not entirely certain I control. The patients keep arriving. The documentation keeps accumulating. And I've stopped trying to reconcile which entries I consciously created and which appeared through that other process, because the system works. Both systems work, and in an ER operating at constant surge capacity, maybe that's what it takes. Splitting yourself across parallel streams, processing the visible and the marginal, triaging the patients who arrive through doors you can see and the ones who appear directly in treatment bays, having somehow bypassed every conventional entrance. They all bear my signature. They all receive appropriate care, and they all know my name, even the ones I have no memory of meeting. Because somewhere in the shadow triage running parallel to my conscious awareness, I've already assessed them, documented their conditions, and assigned them to the beds that exist in the margins between what the tracking system shows and what actually requires treatment.